Welcome, Zoo Assembliers! My name is Zouk Azalishvili and I'm the founder of Zoo Assembly. Zoo Assembly is an online podcast for the highest yield basic science and clinical knowledge tested on USMLE Step 1 and USMLE Step 2 CK. The information discussed in this podcast is intended only for educational purposes. It's not intended to prevent, diagnose, or to treat the medical conditions in real clinical practice, nor is it intended to reflect the policy and the guidelines of various health institutions. Simply put, we serve you to butcher your step exams. Please subscribe to our podcast, Facebook, Instagram pages, and the YouTube channels down below in the description of this episode so that we keep you tuned for the news at Zoo Assembly. Now, let's start rolling. Today we will start the surgery series from the USMLE Step 2 CK series. And surgery topics will be divided into two episodes. This is the first part of the surgery series. And before we start, let me tell you that here, for the USMLE Step 2 CK episodes, we will talk about many different conditions which are united under the certain headline, for example, surgery, but these conditions are not necessarily interconnected with each other. So we will discuss many different conditions with various presentations and diagnostics and the treatment across the surgery in this case. So let's start. The first disease that we're going to talk about surgery is abdominal compartment syndrome. And before we talk about the clinical manifestations, we should definitely start talking about the cause or pathophysiology of the ACS or abdominal compartment syndrome. This is when intra-abdominal pressure increases significantly, causing the intra-abdominal organ dysfunction. Basically, compartment syndrome in any enclosed space is increased pressure within that space, causing dysfunction of the contents of that space, in this case, abdominal organs. The risk factors for abdominal compartment syndrome are major intra-abdominal surgery or intra-abdominal diagnosis, for example, pancreatitis, because when we perform abdominal surgery, there might be the fluid shifts and the person might get the fluid accumulation inside the peritoneal cavity, which in itself can cause abdominal compartment syndrome. At the same time, pancreatitis, as we know, can cause systemic inflammation with resultant increased vascular permeability, and this vascular permeability can also cause the fluid accumulation in the peritoneal cavity, and it will also cause the ACS. Intra-abdominal fluid collection due to anything, as we already mentioned, can cause abdominal compartment syndrome. And when we say due to anything, we literally mean due to anything. For example, if the patient has intra-abdominal bleeding, that can also cause abdominal compartment syndrome. Or let's say the patient is someone who has long-standing cirrhosis with ascites, and this ascites can also cause ACS. Surprisingly, fluid resuscitation, especially if it's massive fluid resuscitation, can also cause the abdominal compartment syndrome. For example, in case of trauma, in case of septic shock, and etc. Now, as for the clinical features of ACS, first of all, we should mention that the patient will have very tense and very distended abdomen. And it also makes sense because if the pressure inside the peritoneal cavity is too high, then we can certainly feel that increased pressure from the outside when we palpate the patient's abdomen because it will be very tense, stretched, and distended. At the same time, if the patient who has abdominal compartment syndrome is at the same time on mechanical ventilation, he or she will require increased ventilatory settings. What I mean is that we will need to increase PEEP, for example, and there is a very, very specific physiologic reason behind this particular phenomenon. When we increase the intra-abdominal pressure, then can you tell me what happens to the height of the diaphragm? I hope you're saying that the diaphragm is elevating, right? It becomes located a little bit up than it normally is. Therefore, it increases intrathoracic pressure and it's harder for the lungs to expand. Therefore, we might need to increase PEEP. At the same time, person who has abdominal compartment syndrome has increased central venous pressure. Can you tell me why the person with ACS has the increased central venous pressure? Well, let me tell you. I hope you already came up with this, but we'll still explain it. When we have increased pressure inside the peritoneal cavity, this pressure is transmitted back to the retroperitoneum and the structures within the retroperitoneum, including inferior vena cava. And when we compress the inferior vena cava from the outside, that definitely increases the pressure inside the IVC, which is one of the central veins. So CVP will increase. But this phenomenon also has another very important hemodynamic consequence. Since we compress the inferior vena cava by increased intra-abdominal pressure, then venous return to the right heart will decrease. Subsequently, the cardiac output will decrease, so the patient who has ACS will likely have hypotension and the reflex tachycardia. At the same time, this person might have decreased urine output. And before we start explaining that, let me pose the mechanism of this phenomenon in a question format. Can you come up with an idea of why the patient with ACS might have decreased urine output? I hope you can, and we'll still discuss it. When increased intra-abdominal pressure is transmitted to the retroperitoneal organs, it also compresses abdominal aorta to a certain degree. And if we compress abdominal aorta, then definitely the blood flow through the branches of abdominal aorta, decreases. And one of the branches of abdominal aorta is renal artery, and we have two renal arteries for our kidneys. And if we decrease the renal perfusion due to this mechanism, then we will decrease the GFR, and therefore we will have decreased urine output. Finally, we should talk about the management of ACS. And there is definitive management here, but before we talk about the definitive management of ACS, let's talk about the measures which will help us stabilize the patient. First of all, we should try to avoid over-resuscitation with the intravenous fluids. And the reason for this is that, as we mentioned, over-resuscitation with the fluids in the context of trauma or sepsis can actually cause ACS. At the same time, we should try to decrease the intra-abdominal pressure as much as we can. And this could be accomplished by the nasogastric tube. If we decompress the bowels, then the pressure inside the peritoneal cavity will also decrease to a certain degree. And if there is fluid collection inside the peritoneal cavity, then we can do paracentesis, which means the needle removal of the peritoneal fluid. Additionally, if we sedate the patient, this will increase the abdominal wall compliance, and therefore it will decrease all of that tension which is created by the increased intraperitoneal pressure. All of these three measures are only stabilizing and temporizing measures. In other words, this is not a definitive management. So for definitive treatment of ACS, we need surgery. We should do the surgical decompression. And this was an abdominal compartment syndrome. Now we will discuss acute limb ischemia. And just as we did for abdominal compartment syndrome, here let's start with talking about the causes of acute limb ischemia and the pathophysiology. What is acute limb ischemia? Acute limb ischemia is when the thrombus gets, basically it lodges into the artery of the extremity, especially the lower extremity, and it causes significant ischemia to the extremity. And the question is, which condition can cause the thrombus to lodge into the extremity artery? And this thrombus might come from the cardiac diseases. Can you think of any cardiac problem that can send the thrombus to the lower extremity arteries? I hope you're telling me about atrial fibrillation, because if we recall this, atrial fibrillation has a predilection to make thrombi, especially if it's chronic AFib, meaning more than 48 hours, and this thrombus is first located in the left atrial appendage, but then it has the risk for embolizing into the systemic circulation, including the lower extremity arteries. Another heart condition which can potentially cause acute limb ischemia, or ALI, is left ventricular thrombus. Let's describe a patient who has had acute myocardial infarction, let's say 3 months ago, and well, if he has had MI 3 months ago, then please tell me what kind of modification there will be in his myocardium. I hope that you're telling me that he will have scar by this time, right? This scar, which is non-contractile tissue made up of type 1 collagen. And since this is a non-contractile tissue, the blood flow across the scar becomes very sluggish, and therefore coagulation factors have the time to just come together and aggregate and make a thrombus. That's why left ventricular aneurysm is a significant risk factor for a left ventricular thrombus. And just like the thrombus precipitated by the AFib can embolize into the systemic circulation, the same way thrombus from the left ventricular aneurysm can embolize in the systemic circulation, including in the lower extremity arteries. Additionally, if the patient has infective endocarditis of the left-sided valves, that can also cause the acute limb ischemia. Let's imagine that the patient has mitral valve endocarditis, and let's say that this is acute endocarditis caused by Staph aureus. We know that Staph aureus is highly virulent organism. This is why it causes acute rather than subacute endocarditis. And another feature of Staph aureus endocarditis is that it has very large vegetations. Therefore, it's very easy for these vegetations, or at least parts of these vegetations, to just pinch off the whole mass and then embolize systemically. And this is what might happen in a patient with infective endocarditis. It's not only about the cardiac condition, which can predispose to acute limb ischemia. The pathology in the arteries itself can also cause acute limb ischemia. And I'm talking specifically about the peripheral arterial disease. This is when patients have atherosclerotic plaque in their arteries, and then we know that atherosclerotic plaque is covered by the endothelium from the outside, but it can rupture at the neck, and then it will expose all of that cholesterol and lipid-laden macrophages, which will trigger thrombosis there. And thrombosis at the neck of the ruptured atherosclerotic plaque can occlude the whole lumen of the artery, causing the acute limb ischemia. And finally, we might have acute limb ischemia due to iatrogenic causes. If patient undergoes some kind of vascular procedure, and if the surgeon inadvertently damages vascular endothelium, this damage might also trigger thrombosis, which will finally cause the acute limb ischemia. Okay, now that we've talked about the causes and pathophysiology of the ALI, let's talk about the clinical features. And there is one easy way to consolidate that knowledge about the clinical features of ALI. This is mnemonic of 6 P's of the acute limb ischemia, meaning there are 6 symptoms and signs, all of which start with the letter P. The first is pain, and pain happens because if we just cut off the blood supply to the muscles of the lower extremities, then definitely anaerobic glycolysis becomes more intensive and the lactate accumulates, which then causes pain. The patient will also have pallor. Pallor means abnormally white skin, and it also makes sense that if we cut off the blood supply, then the skin will be less red because the blood is what makes skin red. So if there is insufficient blood in the ischemic part of the lower extremity, then that ischemic part will be pale. The patient might also have paresthesia, which is this abnormal sensations of tingling and other neurological sensations, and this is caused by ischemia of the lower extremity nerves. Pulselessness is the 4th P from the 6 P's, and pulselessness is caused also by the fact that blood flow is decreased or completely stopped in this condition. The patient will also have poikilothermia, which in this case means cool extremity. Let me remind you that blood is what makes our body warm, our skin warm, and therefore if there is a specific segment of our extremity where blood flow is disrupted, then that part of extremity will be less warm compared to the other part, so it will be cool. And finally, in the late stages of acute limb ischemia, we might get paralysis. And paralysis will happen when the muscles of the ischemic extremity segment become paralyzed. I mean, if we decrease the blood flow to the muscles, then oxygen delivery to the muscles also decreases. And if we recall from our step 1 knowledge, oxygen is an essential part for ATP production by the electron transport chain, meaning if there's no oxygen, there's no ATP, and if there's no ATP, then there is no muscle contraction. And this is how paralysis happens in acute limb ischemia. Finally, now that we've talked about the cause, pathophysiology, and the symptoms of ALI, let's finish and wrap this condition up by the management. Well, once we suspect the acute limb ischemia, we should start giving anticoagulation to the patient. And preferentially, this should be heparin, because we need anticoagulant which will start working immediately, because after 6 hours of ischemia, the patient's extremity will be probably unable to be salvaged. I mean, it will probably be lost, and the patient will have to undergo amputation of that leg. And the reason we use anticoagulation in acute limb ischemia is that heparin prevents the further progression of that thrombus. Heparin will not degrade already existing thrombus, but it will prevent expansion of that thrombus so that we will prevent further decrease in the blood flow to already ischemic segment. Another course of management for acute limb ischemia is either thrombolysis or surgery, i.e. thrombectomy. In other words, either we inject TPA or tissue plasminogen activator to the ischemic extremity, which will break down the existing thrombus, or if the patient has some kind of contraindication to TPA therapy, for example, if the patient has had some recent surgery in the last 2 weeks, or if patient has had the intracranial bleeding or has any bleeding diathesis, then we will not use TPA, we will use thrombectomy. In other words, we will mechanically remove this thrombus to salvage the ischemic extremity. I hope acute limb ischemia was clear for you, and this is how we will end this particular condition. Now we will discuss the blunt abdominal trauma and its management algorithm. First of all, let's define what blunt abdominal trauma or BAT is. BAT is when the patient has abdominal trauma without any penetrating injury. So there is no penetration, there's no open wound. And when the emergency department admits the patient with blunt abdominal trauma, the first question that we should ask ourselves in the management of this patient is the patient hemodynamically stable or unstable? And let's just get back a little bit and talk about the hemodynamic stability and instability. And I'm doing this because I think the definition of hemodynamic stability and instability is not quite clear for many of us, many medical students. And the reason for this is that there is no official definition of this term. But what we know is that patient is considered hemodynamically stable if this patient has either chest pain or shortness of breath, hypotension, or confusion. And all of these signs or symptoms indicate insufficient perfusion of the end organs. So whenever you see the patient and you see that the patient either has altered mental status or chest pain, hypotension, then we can say that this patient is hemodynamically unstable, and vice versa. If the patient has none of those symptoms, then the patient will be hemodynamically stable. Okay, as we already mentioned, this is the first question that we ask once we see the patient with blunt abdominal trauma. And let's first talk about patient who has BAT and is stable. The second question that we ask is, does this patient have peritonitis or not? And how do we suspect whether the patient has peritonitis or not? Well, this is based on the presence or absence of the peritoneal signs. And peritoneal signs are abdominal rigidity, also rebound tenderness, and generally patients who have peritonitis want to lie still on the stretcher. They cannot move because even a slight movement causes excruciating pain for them, because it causes movement of this peritoneum, like visceral, parietal peritoneum, and when they rub against each other, that causes this excruciating pain. Let's say that our patient with BAT is stable and she or he has peritonitis. Then the best next step in management is laparotomy. In other words, we will take this patient to the OR to open up their abdominal cavity and to repair whatever there is there. However, we can consider performing the CT of abdomen and pelvis en route to the OR, meaning while we are transferring the patient to the OR, we might need to do the CT of the abdomen and pelvis to see what exactly is causing this patient's peritonitis. Regardless, whenever the patient has peritonitis, there is just only one correct course of management on the USMLE Step 2 CK exam, at least. This is laparotomy, because peritonitis is immediately life-threatening and it's an extremely serious condition. Okay, now that we have discussed the stable patient with peritonitis, let's move on to the stable patient without peritonitis. If the patient does not have peritoneal signs, then the next question we ask is, does this patient have free fluid in the peritoneal cavity? And the imaging modality of choice to discover whether this patient has free fluid in the peritoneal cavity or not is something called FAST scan, which means focused assessment with sonography for trauma. And FAST is basically the focused ultrasound of the peritoneal cavity, pelvic cavity, pleural, and sometimes pericardial cavities as well, to see if there is any fluid accumulation in any of these hollow spaces. If there is fluid accumulation, then we will do CT of the abdomen and pelvis to find out the exact cause of the fluid accumulation. However, if there is no fluid accumulation, then now we have the patient who has blunt abdominal trauma, but this patient is stable. This patient does not have peritonitis, and she or he does not have any free fluid on the fast scan, which means that this patient is more or less stable and less acute. So we can potentially do CT of the abdomen and pelvis, or CTAP, or we can actually do simply serial abdominal exams, and this is based on our suspicion for the abdominal injury, meaning whether we do the CT of the abdomen and pelvis or serial abdominal exams depends on what we think is causing this patient's blunt abdominal trauma. Right, we have now discussed patient with BAT who is hemodynamically stable. Now let's move on to the other side of the algorithm, where we have the patient with BAT who is hemodynamically unstable. And just like it was for the stable patients, the first question that we ask for the unstable patient is, does this patient have peritonitis or not? And do you remember what we said happens when the patient has peritonitis and peritoneal signs? I hope you do. Well, the patient is taken directly to the OR. We need to do laparotomy, meaning we need to do the open surgery on this patient's abdominal cavity to find out the cause of peritonitis and to repair that cause too. But now let's say that we have an unstable patient who does not have peritoneal signs and therefore probably does not have peritonitis. Then just as it was for the stable patient, in this case, we also do the fast scan to discover whether there is the free fluid in the patient's abdominal cavity. If there is the free fluid, then we take this patient to the OR to do the laparotomy. And let me make one just comparing and contrasting parallel between the unstable and stable patients. If you remember, we said that when patient is stable, does not have peritoneal signs, and there is free fluid on the fast scan, we do the CT of abdomen and pelvis. In contrast, if the patient is unstable, does not have peritoneal signs, and does have the free fluid on the fast, then we do laparotomy instead of CTAP. And finally, if the patient is unstable, but this patient does not have peritonitis and he or she does not have any free fluid on the fast scan, then we can do either CT of the abdomen and pelvis, but that will happen only after we resuscitate the patient with the intravenous fluids, or we can do the DPL. DPL means Diagnostic Peritoneal Lavage, and this test is not extensively done anymore because it's invasive. However, let me explain the procedure and the rationale behind it. Diagnostic peritoneal lavage means that we take out the peritoneal fluid and we are checking if there is any blood there, because sometimes the fast scan might not be able to detect the small amounts of fluid in the peritoneal cavity. However, if we do DPL, then we can possibly detect if there is any fluid and if this fluid is blood. So this is how we manage the patient with blunt abdominal trauma. We have already discussed the blunt abdominal trauma, but right now we will talk about blunt chest trauma, which is abbreviated as BCT. And just like it was for blunt abdominal trauma, for the blunt chest trauma, the first question that we ask is the patient with blunt chest trauma hemodynamically stable or unstable? Let's first talk about the patient who has blunt chest trauma and is unstable. In that case, first of all, we definitely start the primary survey of this patient. If you remember, there is a mnemonic, right? There's A, B, C, D, and E. So A stands for airway. We check if her or his airways are open. We also check for breathing, whether he or she needs mechanical ventilation or other means of oxygen delivery. We also need to check circulation. Circulation is checked by checking the pulse and blood pressure. This determines whether the patient needs hemodynamic fluid support. D stands for disability, and this pertains to the neurological disabilities which might be present in traumatic patients. And finally, E is exposure, meaning we need to expose the patient's body and we need to find out if there are any additional injuries or some other causes of the patient's instability. Okay, let's get back to this unstable patient with blunt chest trauma. We do resuscitation with IV fluids and possibly ventilation if we need it. And also we need to evaluate this patient. For the evaluation, we will do the fast scan. And as we already discussed, the fast scan detects if there is any fluid in the pleural cavity, pericardial cavity, peritoneal, and the pelvic cavity. But in this particular case, since we're talking about the blunt chest trauma, we will particularly pay attention to pericardial and the pleural cavity while assessing the chest. At the same time, we need to do the chest x-ray. And the rationale behind chest x-ray in case of blunt chest trauma is that chest trauma can cause pulmonary contusion, which is literally the damage of the pulmonary parenchyma by this mechanical trauma, and there might be also a hemorrhage inside the alveoli. We also do the ECG. The reason for why we do the ECG in blunt chest trauma is that just like we can have pulmonary contusion in case of the lung damage, we might also have myocardial contusion, which means that there is myocardial damage by this mechanical stress that the patient experienced, and this might cause abnormal findings on the ECG. We might also have increased troponins on the labs, so it might look like a little bit like MI. However, this is myocardial contusion. And if we need, then we might also perform the chest tube placement in this patient. Let's say that the patient experienced tension pneumothorax or hemothorax in the context of blunt chest trauma. In that case, we will definitely need the chest tube, but please keep in mind that the chest tube is not necessarily inserted in the patient who is unstable with the blunt chest trauma. After we resuscitate our patient and we do these initial measurements and chest x-ray and ECG, then the next question we ask is, has this patient achieved hemodynamic stability or not? If the patient is still hemodynamically unstable, then there is no other choice other than to do thoracotomy, which means that we will do open surgery of the patient's thorax and we will see whatever is causing this patient's instability. However, if the patient has achieved hemodynamic stability after initially being unstable, then we need to do additional imaging studies to find out the exact cause of this patient's initial instability. And in the imaging studies, I mostly mean the CT scan, because it will give us a very good anatomic specification of what might be wrong in this patient. Okay, this was one side of the algorithm. Let's talk about the patient who has blunt chest trauma, but this patient is hemodynamically stable. If the patient is stable, meaning the patient is not hypotensive, there is no significant tachycardia or altered mental status or chest pain or shortness of breath, then we will ask ourselves if this patient has any serious injury on the examination, meaning we should think about the exact cause of the blunt chest trauma. The patient might have had the motor vehicle accident, which might be the cause of blunt chest trauma, or that might be the physical altercation. So anyway, we ask, how serious is the injury of this patient? If the patient has a very serious injury and high-risk mechanism of the injury, then we actually repeat the algorithm that we already described for unstable patients, meaning we will start to resuscitate this patient accordingly, for sure, and also we will evaluate this patient through the fast scan and chest x-ray and ECG. and then we will ask if the patient has stayed hemodynamically stable or not. However, if the patient has no serious injury and there is no high-risk mechanism of the injury, we will still do chest x-ray and the ECG to see if there is any abnormal findings. If there are any abnormal findings, then we need additional imaging tests, and in this case I mean CT. However, if there is no abnormal finding, then we can actually discharge this patient, or we can observe this patient for several hours in the hospital, and if his or her condition stays stable, then we can finally discharge them home. This was the discussion of the management of blunt chest trauma patient. I guess it will be logical if now we will discuss the blunt thoracic aortic injury, because we have already discussed the blunt chest trauma, and now let's talk about aortic injuries. And the first thing that we need to understand about BTAI, which is blunt thoracic aortic injury, is that it usually happens after acute deceleration. For example, let's imagine that there's a patient who is driving a car and that there is some kind of accident on the road, and this patient just puts on the brake and there is this rapid deceleration. And also we need to recall some of the aortic anatomy here. The thing is, ascending aorta is relatively mobile. However, descending aorta is relatively fixed, because if you recall this, there is a structure called Ligamentum Arterialism which connects the aortic isthmus, or the junction between aortic arch and descending aorta, to the left pulmonary artery. And by the way, do you remember what structure gave rise to Ligamentum Arterialism? I hope you do. And it's very cool if you remember this. This is ductus arteriosus. And the idea is that mobile ascending aorta is displaced forward during deceleration, while descending aorta stays back. And this creates a tension at the site of the aortic isthmus, and this might cause the aortic wall injury. Now, the specific type of aortic wall injury depends on how many layers of the aortic wall gets damaged, and whether this damage is unilateral or bilateral. Let's say that we have unilateral aortic wall injury, and let's say that we have tear of only intima. In that case, we will create a false lumen in the aortic wall. In that case, traumatic aortic injury will look like aortic dissection, because this is an incomplete rupture of the aortic wall. However, let's imagine that we still have unilateral aortic wall injury, but in this case, it's not only the intima which is torn, but it's also media. It means that blood is accumulating there, and it's confined and restricted by adventitia of the aorta. This will be aortic pseudoaneurysm. This is totally analogous to the left ventricular pseudoaneurysm, which happens anywhere from 3 to 14 days after myocardial infarction. If you remember, in the left ventricular pseudoaneurysm, the endocardium is basically torn and destructed. Myocardium was also destructed, and there is this wall rupture which is confined within epicardium. In this particular case, we don't have endocardium, but we have intima. Instead of myocardium, we have the media, and instead of the epicardium or visceral pericardium, we have adventitia. So in this case, adventitia accommodates all of that fluid, and this type of aortic injury is extremely dangerous because this can actually rupture, because at some point adventitia will not be able to accommodate all of that blood and all of that pressure, and it ruptures, and we will have the exsanguination of this patient in the mediastinal cavity, and the patient will most likely die. Let's now discuss what happens if we have bilateral incomplete aortic wall injury. In this case, what happens is that there is a rupture of intima and media bilaterally, I mean on two sides of the aortic wall, but adventitia stays intact on both sides. And in this case, we have a very, very interesting phenomenon. The torn intima and media, they just fold back on themselves and they create something called pseudo coarctation. Do you remember what aortic coarctation is? I hope you do, but let me still remind you. Aortic coarctation is when we have narrowing of the aorta, either anterior, either proximal or distal to the ligamentum arteriosum, and that's true aortic coarctation. However, in case of incomplete bilateral aortic wall injury, we will have pseudocoarctation because this coarctation is actually created by the folded intima and media which narrow down the aortic lumen, and the patient will have the symptoms of aortic coarctation, meaning there might be ischemia and therefore ischemic pain to the lower extremities, and there might be hypertension in the upper extremities. However, in contrast to the true aortic coarctation, the pseudocoarctation is very emergent condition because just like it was in case of pseudoaneurysm of aorta, here as well we have continuous blood accumulation around this pseudocoarctation, which might actually cause the rupture of the aorta and sudden death of this patient. And finally, we will talk about probably the easiest form of blunt thoracic aortic injury. This is when there is complete tear of the aortic wall. And can you imagine in your mind what will happen if there is complete tear of all of the intima and media and adventitia? Yes, you're right. All of the blood will just spill out in the mediastinal cavity. Sometimes it can also penetrate the pleural cavity, but the idea is that the patient can literally sanguinate from aortic injury, and it's almost 100% fatal. Aorta is not certainly the only significant vessel that can be damaged, causing the hemodynamic instability or even death in patient. Another vessel, the pathologies of which is extremely important and high yield for USMLE Step 2 CK, is carotid artery. And now we will discuss carotid artery dissection. Carotid artery dissection is when there is a tear in the carotid artery intima and the blood is accumulating in between the intima and media. And when we create this false lumen in the wall of the carotid artery, then it can obstruct the true lumen of the carotid artery, causing the cerebral ischemic signs. But we'll definitely get to that. Let's first start with the cause and the pathophysiology. The most common cause of carotid artery dissection is actually a trauma. Let's imagine the patient who is undergoing some very extensive and severe neck manipulations. For example, this might be a patient who is undergoing chiropractic procedure, or we can say that, well, let's say the patient is doing some kind of exercise. For example, the patient is performing the yoga exercises without having sufficient knowledge of how to do these exercises correctly. In that case, the patient might actually put his or her neck in a position that can compress and damage one of her or his carotid arteries. Also, if you remember that very famous UWorld illustration where the child has the toothbrush in his mouth and then there's some kind of trauma to the oral cavity, and this toothbrush can penetrate deep and it can puncture the carotid artery. That can also cause carotid artery injury. However, surprisingly, carotid artery dissection can also happen spontaneously. However, there are several underlying contributors to the carotid artery dissection. For example, if the patient has hypertension or, let's say, smoking history or connective tissue diseases, then this patient might be at risk for carotid dissection. And the idea is that all of these conditions create the vascular changes. For example, they create the hyaline arteriolosclerosis, or they weaken the vessel wall due to vasculitis, for example, when we talk about connective tissue diseases. And all of that weakening and remodeling can actually contribute to the carotid artery dissection. Now, what is the clinical presentation of carotid artery dissection? Usually, it's basically unilateral carotid artery that gets dissected. It's very rare to have bilateral carotid artery dissection at the same time. Therefore, since carotid dissection is mostly unilateral, we will have a unilateral head and neck pain. Neck pain happens because carotid artery is located in the neck, certainly, and headache happens because, if we recall from our neuroanatomy, the carotid artery provides the anterior and middle circulation of the brain and of the cranium. Therefore, the disruption of this circulation might be a contributor to the headache. We might also have a transient vision loss. And the reason for this is that if the patient has common carotid artery dissection, then it means that the blood flow to the internal carotid artery and all the branches of the internal carotid artery is disrupted. And let me remind you that there is one very, very high yield branch of the cerebral part of internal carotid artery, and this branch is ophthalmic artery. Ophthalmic artery goes into the optic canal together with the optic nerve, and it supplies potentially everything in the orbits. The eye, the globe itself, and all of those structures. Even central retinal artery is the branch of ophthalmic artery. Therefore, if the blood flow is disrupted in internal carotid artery and ophthalmic artery, then we might have transient vision loss, which is also called amaurosis fugax. Another clinical feature that might characterize the carotid dissection is ipsilateral partial Horner syndrome. And do you have any thoughts of why the carotid dissection might actually cause Horner syndrome? I hope you do. And the reason for this is that sympathetic plexus innervating the face whirls around the carotid artery. All of the components of carotid artery: common carotid, external carotid, and internal carotid artery. And we will have partial Horner syndrome with the ptosis and meiosis, but there will be no anhidrosis. And the reason for this specific caveat is that the sympathetic plexus innervating the facial sweat glands goes along the external carotid artery. But let me tell you that carotid artery dissection usually spreads along the internal carotid artery, so it rarely affects the external carotid artery. This is why we will have partial Horner syndrome. And by the way, even though this is not a topic of surgery, let me ask you one thing. Do you remember the type of headache which is also characterized by partial Horner syndrome? Yes, that's right. This is the cluster headache. Okay, now let's get back to the carotid dissection. In addition to the unilateral headache, neck pain, and the partial Horner syndrome, the patients with carotid dissection might have the signs of ischemic, cerebrovascular accident or stroke. There might be focal weakness, i.e. focal neurological deficit, which will usually indicate ischemia in the distribution of middle cerebral artery, because MCA is the largest branch coming off of the cerebral part of internal carotid artery. Okay, now, when we suspect the carotid artery dissection, then what tests should we order in order to confirm it? Well, we need some kind of neurovascular imaging, and the most commonly used imaging modality is CT angiography, which will show us any defect and damage in the carotid artery wall. And when it comes to the treatment of carotid artery dissection, well, we start antiplatelet therapy, especially aspirin, to inhibit any thrombus formation. We also might give anticoagulation, but that does not always happen so. And we can actually also give thrombolysis or TPA therapy if there is less than 4.5 hours elapsed after the symptom onset. So it's just like in case of stroke, right? In ischemic stroke, we can give TPA only if the patient has come within this 3 to 4.5 hours of the window. And this was discussion of the carotid artery dissection. Let's move on to one very, very interesting diagnosis, which is called complex regional pain syndrome. And first of all, just like we do for all the conditions, let's describe what the complex regional pain syndrome is. This is when the patient experiences the changes in the sensation and temperature of the extremity or the part of the extremity after some kind of trauma. And you guessed it correctly. The trauma is a very, very common trigger for a complex regional pain syndrome. And in trauma, I specifically mean either fracture or even sprain. Let's imagine the patient, let's say this is an elderly lady who experienced the femoral neck fracture. And, well, she recovered after the open reduction and internal fixation of her femoral neck. And now she complains of the specific changes in her thigh. And we will definitely talk about these changes, which are basically the clinical features of complex regional pain syndrome. But before that, let me tell you that even surgeries can trigger the complex regional pain syndrome. Now, as for the clinical features, well, the name itself tells us what the predominant symptom is. The name of this disease, let me remind you, is complex regional pain syndrome. Therefore, we will have the pain on the extremity above that fracture, previous fracture, or the sprain. But this pain will be regional. This is why it's called regional pain syndrome. Regional pain is different from dermatomal pain. Dermatomal pain is when the pain spreads along the certain dermatome or along this certain spinal nerve, which innervates the particular basically segment of the skin. But in this case, it's not dermatomal pain. It's this diffuse regional pain which might involve several dermatomes above the site of previous fracture or the sprain. But apart from pain, the patients usually complain of paresthesias. There might be a stinging sensation, tingling, burning sensation. At the same time, there are some vasomotor changes in the extremity. We will have the edema. There might also be the abnormal sweating. There might be altered skin temperature, for example. There might be increased temperature over that area of the extremity. And also there might be the changes in the hair or skin or the nails over that area. When it comes to the diagnosis of complex regional pain syndrome, let me tell you that it's primarily clinical. However, if we do the X-ray, we will see that there is this segmental demineralization of the underlying bone, which experienced either fracture or basically sprain of the joint. And if we do the bone scintigraphy, we will see increased uptake of the tracer in the affected extremity. And finally, we should discuss the management of this condition, which will be mostly non-pharmacologic at first. In other words, we will try to do physical therapy. We will also suggest occupational therapy and the exercise to the patient. And the patient will try to just get used to this condition and to alleviate it. But then, if the patient has significant pain, then we can try the medications. NSAIDs can treat the pain of complex regional pain syndrome, and at the same time, anti-neuropathic medications, meaning anti-pain medications medications for the pain caused by neuropathy can also be used. For example, pregabalin, gabapentin, TCAs, they can be used in this syndrome. And this was the discussion of complex regional pain syndrome. And the final topic for today will be the GCS score, which is Glasgow Coma Scale. Glasgow Coma Scale is the scale which is used to assess the consciousness and alertness of mostly adult trauma patients. And I emphasize the word adult because the Glasgow Coma Scale does not work that well for the pediatric population. For the kids who are trauma patients, we usually use the PCARN rules, which we'll talk about in other episodes. But now let's concentrate on the Glasgow Coma Scale. There are 3 criteria for this. So there's eye opening, verbal response, and motor response. Eye opening gets the maximal point of 4, verbal response gets maximal point of 5, and the motor response gets maximum point of 6. And the idea is that if the patient can open the eyes spontaneously, then that's the 4 point. If we need the verbal command to make the patient open the eyes, that's 3. If the patient opens the eyes to the pain, that's 2, but if the patient does not open the eyes at all, that's 1. For the verbal response, if the patient is completely oriented to time, place, and person, that's 5. If the patient is slightly confused, that's 4. If he or she is using some inappropriate words and just throwing them out, that's 3. If she or he moans and just emits incomprehensible sounds, that's 2. But if there's no verbal response, that's 1. Finally, for the motor response, if patient obeys our commands, that's 6. If the patient can localize the pain by pointing to it, that's 5. If the patient withdraws their extremities from the painful stimuli, that's 4. If the patient has decorticate posturing, which is flexion of the upper extremities and extension of the lower extremities, we won't go deep into the pathophysiology of this. This is 3. If the patient has decerebrate rigidity, which is hyperextension of both upper and lower extremities, that's 2. And if there is no motor response, that's 1. So minimal score in GCS is 3, while maximal is 15. And I suggest that you go and Google calculating the GCS score and just practice doing this, because this is how you will get used to it. So we have come to an end of our today's discussion, and let's summarize everything that we have talked about today. We have talked about many different diagnoses across the surgery. However, our episode today was not comprehensive by any stretch, and we cover many more conditions on our ZUSMLE classes. But however, the main take-home message for practically all of these conditions is to know their current diagnostic algorithm, treatment, and pathophysiology. You can leave the voice message on this episode to let us know how we can improve our podcast for you. So thank you for your kind attention, ZUSMLEers, and see you on the next episode.